get some swelling with it. And the causes vary, but often relate to altered loading of the kneecap. So the things to consider would be weakness in the buttocks and thighs, some tightness in the hamstrings and calf, and sudden change in activity. Often someone doesn't do something for a while or never done it, and then they suddenly do too much of it. Okay. Being overweight is also a contributing factor. Treatment options include strengthening any weak or underactive muscles and stretching any short or tight muscles. That's quite a nice, to be fair, that's quite a nice practice for most musculoskeletal conditions. But what's important is to identify what activities are causing or increasing pain, and modifying those activities make a difference. So you might reduce the amount of kneeling. Actually, and you see this in jumping, running, sports where you do frequent starts and stops, which is running impact. So the ones that are common affected are basketball, football, volleyball, and as we say those kind of Outcome, which is very nice, and it's something that is sport. But you can look at Outcome, and now Outcome is very nice. Point of care, in which you can do, and you can see the optimal tendon, there's some signal change to the and itself and so many we then move on to Hopper syndrome, which has two names, Hopper disease, or fighter. And essentially this is the soft tissue that's defining the when people describe pain, for example, walking downstairs, this is what I think about. This one is quite helpful to perform bilaterally because often when you perform it on the asymptomatic other side, they go that's uncomfortable but nowhere painful. Treatment of this is tapering, rehab, medication to make it over, and not painful. Offloading or linking the tissue problem helpful. Some people do often have using injections. I'm a bit more, I treat younger patients, older patients. I'm a bit more reluctant about injections in younger patients, so I try to offload and do physiotherapy. There is a role for it, but I'm more selective. Okay. I'm going to move on just very quickly to talk about patellar instability. Just say that there's a range here, going from joint subluxation to joint dislocation. We try and manage this operatively, but sometimes operative management is indicated. So thank you very much.
Thanks, Rick. Great whiz through anterior knee pain. Very difficult topic, so glad to hear about that. Next we've got Chim Gupti up. Fortunately, Chim's a very quick speaker, so I know we'll catch up sometime. Go for it, Chim.
Thanks very much. Morning, everyone. Just to start with, it'd be really good to know the audience. How many of you are physiotherapists? Put your hand up. Okay. How many of you are GPs? Great. Now, the next topic that I'm going to talk about is it'd be really good to understand how knowledge is diffused out. So everyone put their hands up. Everyone put their hands up. Now put your hands down if you don't treat ACL injuries. If you don't treat ACL injuries, okay? Now put your hands down if you have not treated someone who's had a lateral tenodesis with their ACL. Not treated someone. Okay? Now put your hands down if you've heard of lateral tenodesis. Okay, so you've all heard of it, which is interesting because when I was training back in 98, 99, we've never heard of it. And it's really come to the fore over the last decade or two. And it's a great example of science changing practice. And arguably, the soft tissue knee injuries in ACL, although it's not tissue knee, this is the one benefit of the change practice. But it's not new. Hago described it back in 1872. Now, we go back to how we determine the ACL, and this is both classic valgus external rotation with a foot planted type injuries. And you can just about with the Michael Owen one see a pivot type injury. Now, classically, we all know about the anterior draw, which you can just about see here, and the ligaments, okay? And we quite like doing it in these two manners, but they are really examples of sagittal plane instability, so really the sideways movement of the knee. And this is what you do. You are pulling the tibia forward and revealing anterior translation of the tibia because the ACL is torn. However, most symptoms are probably from this type of phenomenon, which is the pivot shift. It's a rotational phenomenon. It's not a translation, it's a rotation. And the biomechanics of the pivot shift is very different to the biomechanics of the anterior translation. And this is something we take you through because, as you said, you're all aware of lateral tenodesis because patients are undergoing it more and more. And this is the basis of it. If the iliotibial band is a red structure, what you're seeing, and that is what you're seeing here. And the issue is that even when we do ACL reconstruction, if the patient has a really high grade of pivot shift preoperatively, many studies have shown that even with an ACL reconstruction, and some surgeons and it's a real journey from anatomy to biomechanics and pathoanatomy to trying some operations out in cadavers in the lab to changing practice. Okay, so I'm going to take you through some of that. Anterolateral structures of the knee have been shown to consist of. It's very variable, but really you hear about the anterolateral ligament. Is it there, is it not there? It's variable. But the point is that there are some structures on the anterolateral aspect of the knee that seem to control pivot. And the deep band of the iliotibial band, the Kaplan's fibers are also important. Now you don't need to know the details, but you do need to understand that if you restore some of that integrity, one way or another, because it's away from the center of rotation of the knee, it actually controls pivot better than something in the center of the knee, like the ACL. Okay, and these are the anatomical landmarks of these anterolateral structures. Now, this is quite a big incision that we did, partly because it was very early on, about 15 years ago. So this is the iliotibial band. We've taken it, we've whip-stitched it, we've put an anchor in the lateral epicondyle at E4 there, which is where the biomechanics suggested we should put it. We've then passed it deep to the lateral collateral ligament, and then we fix it with an anchor or a staple or a screw. It doesn't really, well, we don't know if it doesn't matter or not, that's future studies. And we've got the incision down to that kind of level now. Why do we do it? Well, it seems in biomechanical studies that it does control rotation, it takes the stress off the ACL, and that's followed up. Those studies were generally between 2010 and 2020, There are also some studies on a similar kind of reconstruction using allograft or autograft. And then over the last 7 or 8 years, the clinical results have come through, and they have suggested that the LET, or at some form of anterolateral reconstruction, reduces the stress loss of the ACL, reduces ACLV rupture and hamstring reconstruction, seems to reduce the pivot shift as well. So this is all the evidence. Now, when do we do it? This is a typical patient who we really worry about as ACL surgeons. Hyperextension and multiple hypermobile joints. And that's the type of, they have a high-grade pivot often. Others, such as young patients, again, there's good evidence that in adolescent patients, the LET seems to reduce re-rupture rate. Revision cases and some anatomy of the bones, the tibia, if the tibia has a high posterior slope. So there's lots of clinical evidence coming through now. So you may see patients with this type of scar. And then really what we're trying to do is get them back to doing this kind of thing without symptoms and then going back to sport. And there is, again, a plethora of evidence now showing that better outcome measures and outcome scores in patients with LETs. However, it's not without risk. First of all, the cosmesis. There's a big lateral scar, particularly people who are concerned regarding a cosmesis don't like it. There is a higher rate of hematoma because there are quite a lot of vessels around there, and there is also a rate possibly of increased lateral pressure as well. So you don't necessarily have to do it for everyone. These are my indications based on personal experience as well as the literature. In pediatric patients, hypermobile patients, or patients with knee hyperextension greater than 10 degrees, revision cases, and possibly a posterior tibial slope greater than 10 degrees as well. So, in summary, the residual rotatory instability persists after ACL reconstruction alone in some patients. The LET reduces some of that rotatory instability and seems to reduce re-rupture rates, and it may enhance return to sport. Don't forget, it's another procedure, it's something else you're doing on the knee, remote from the ACL side. So there are complications, and it needs to be done delicately with someone who's got the experience to do it. Thank you.
Fantastic, great job. I think I'm up next actually. We will, I hope, have some time for questions. I will also speak quickly to try to get through to that. If you could work out myself. I've been asked to speak to you about partial joint replacements. It's a little bit different. You've heard about some clinical conditions. I'm going to talk to you a little bit about a procedure, but some of the things we can do around that procedure to perhaps improve what are already quite impressive results. And I have too many job titles, you're quite right. So my wife tells me anyway. So look, this is where we are. This is our virtuous circle. We have patients who start in a state of good health. They develop symptoms, and then if those symptoms persist long enough, they'll come and find one of you guys in the room, occasionally come directly to us, and then it's our job to figure out what's causing the problem. Actually, a lot of the information you need is in that first bit, the health bit. I actually quite like spending time listening to my patients, which I know is a little atypical for an orthopaedic surgeon, but they often will tell you not only what the problem is, but actually what their aspirations are, where they need to get back to. And that will, to a large extent, inform your treatment choices once you've got the diagnosis. We'll usually tell you the diagnosis and the history as well. The intervention is key. We need to, now that's not always clearly going to be an operation. For more than 50% of patients, certainly in my practice, that's a non-operative option. It's working with you guys in the room to try and find a functional way to get them over their symptoms. But then really key also is that rehab bit. And if we can do something to the intervention, if we do have to do an operation to make it as kind as possible, then that rehab bit afterwards is that much easier. They've got less of a hole to dig themselves out of. So when patients come typically with knee pain, these are the generally speaking interventions. Once you start to think of things which are operative or interventional, you're going to go from an injection when they've got arthritic problems, straight through to an operation. That operation is usually to resurface either part or all of the joint. And trying to decide between those is not only a function of the patient's symptoms, also some of the imaging findings that you can have, and also where they're trying to get back to. So this is what I've been asked to talk to you about. This is what I'm going to focus on more, which is partial knee replacements. And if you want to get a good result out of these, then clear number one job is to find the right patient to have it. This is not an early intervention. This is not something which is before a knee replacement. This is a definitive procedure. If we do this on somebody, if I do this on somebody, I will say to them, I do this with the idea this is the last operation you will need on your knee. Clearly, I'm not always right. 20, 30 years time, this may well wear out. You might need something else. Other bits of your knee might wear out, requiring something else. But these are the prime indications. You want the disease to be isolated to a single part of the joint. Otherwise, there's no point replacing just one bit. You need to look at something more. You need an ACL that's competent. Why? Because this needs to be a joint which is stable. Their problem needs to be degenerative rather than instability. You can sometimes address both of those at once in selected patients. And by and large, you need to get the knee back to a position which is biomechanically sound. So that's back to their native alignment. A fixed deformity is not really possible to fix, to improve on with a partial joint replacement. Now the nice thing is we have tools, and you saw in the hip session, and it's lovely hearing that actually, I think we converge pretty much on similar tools anyway to try and get good outcomes, and three-dimensional imaging is key. It really is in joint replacement surgery, and all of my patients who have joint replacements now have a CT scan first. And that's because I can really tell what their morphology is, and it helps me to analyse the joint, not just preoperatively, but also intraoperatively to try and get the best job for them. And you're going to hear great stuff from John in a minute about alignment. But for partial joint replacement, it allows me to pre-plan the perfect implant that's going to fit in that knee, which involves matching it to all the patient's characteristics, so the position and the size, making sure we're not going to impinge on anything else, but also making sure we're going to recreate the joint morphology, its geometry, so that it can move in a more natural feeling way. And so once we've picked the best implants and making sure that it's going to match the patient's curvature in this way, then we can have a better idea that the ligaments are going to be at the correct tension throughout range of motion. So this is the first step, if you like, making sure it's all going to fit nicely and not cause any problems. We're going to do a smaller approach to get into the joint than we would with a total knee replacement, going either side of the kneecap depending on what type of joint replacement we're doing. This is actually a lateral approach, so we're just going to open the knee up. Sorry if it's a bit gory early in the morning. But then the nice bit is that we can figure out what the knee does throughout its range of motion. So we're going to analyse the actual laxity pattern of the joint intraoperatively. So I'm going to flex the knee gradually through 15 degrees, push it out into valgus for a medial joint replacement, figure out how much space I'm generating as I do that, what that little gap is going to be, and then from that I will have this map of the laxity throughout the whole range of motion, which then can get translated into a graph, which, you know, all of us are used to looking at graphs. It's slightly more user-friendly way of looking at it. And the great thing is now that I can simulate different positions for the joint replacement and figure out what the effect is going to be on the joint movement. So intraoperatively now, we have the tools to pick not only the best implant, but the best place to put the implant so that the knee works almost as naturally as it possibly can. So this intraoperative simulation allows me to figure out, for example, those red dots are where the implants are going to have contact throughout the whole range of motion. And if I get that in a nice straight line in the middle of the femoral component, then I know that I'm going to do a good job. Where this is even more important perhaps is that most soft tissue dependent joint, the patellofemoral joint, right? So, you know, the shoulder surgeons will tell you that soft tissues are important to their joint, but patellofemoral joint, that is the number one joint that requires good soft tissues around it. And so what I need to do here is pretty much find out where the plane, the kneecap wants to land, and try to put the runway, the trochlear component, in the right place. So here comes the patella along there, and what I can do intraoperatively is try to figure out exactly how it's going to strike that trochlear component, make sure it's going to stay in the middle and do its job and transition onto cartilage normally. We do that intraoperatively. We can measure lots of points around there and figure out where the cartilage is, that yellow line, and make sure it matches beautifully with the implant so that you don't get a big jump as the kneecap runs from one bit onto the next. And then really nicely, and this is something that we've worked out sort of independently, this is off-label use, I'm putting a marker here on the front of the kneecap and flexing the knee, and I can then figure out exactly where the centre of the patella wants to lie throughout range of motion, and again make sure that that's going to match beautifully with where the centre of my trochlear component is. So intraoperatively simulating the effects of surgery before I've done the surgery, so that I can then modify the targets for the implantation. And that's a really important concept, I think. It means that I can try out lots of things on a single patient without actually really touching them before I'm committed to the best option. So that intraoperative simulation, I think, is key. So in this example, for example, if the kneecap wanted to come in that way, then I would have an option to either move that way or rotate it. You get the point. So a quick case example, just to illustrate this. This patient of mine, a 74-year-old lady. She's the one and only person in the world who's had a bad experience with a hip replacement previously. In fact, she ended up in ITU for about 3 nights, transfused 4 units. I won't show you the x-ray, but there are some reasons. In a different unit outside of London, I'll hasten to add. She presented with isolated left lateral knee pain, and we won't go into it too much, but she has got bone-on-bone disease in that lateral compartment. For some reason, the Rosenberg view isn't there. Because it's lateral, I tend to get an MRI as well. I think that illustrates a complete loss of cartilage with some bone edema in that lateral femoral condyle as well. The other compartments look okay. So going back to my first slide, this is a good patient now for an isolated lateral compartment replacement. So the surgery, you've sort of had an idea already. This is what it looks like, and this is the outcome on an x-ray. And you say, well, great, that's fantastic, the x-ray looks nice. What about the patient? Well, this is 2 weeks later, and this is what they're doing at 2 weeks. This is her at 2 weeks, and she said, I'm so happy, please take a video and show others. And I would ask you, which leg did we operate on? It's tough to know, isn't it? I can tell it's the left, I know. But so she's quick, don't get me wrong, at 2 weeks, but it's not unusual, particularly for a lateral compartment, adopting all of those practices to minimise the insult to the patient and optimise their outcome afterwards with rehab. So I go back to this virtuous circle. I think we all need to work together. Communication is clearly the main thing between patient and clinician, but also between us clinicians as we try to manage these issues. And I look forward to working with you in the future as well. Thank you very much. Now, you'll hear lots of interesting things now from John. John.
Try and catch up with this lot. Sorry, they're uncontrollable. So I'm going to talk a little bit about alignment theory in total knee replacements. Knee osteology is fairly complicated. We think of it as a hinge. It isn't. So that first picture there is the lateral femoral condyle. It's got 2 quite separate centres of rotation. The medial femoral condyle, slightly separate areas as well. So there's a lot of sliding, there's rolling, there's shear as well. Each knee is completely unique, and no total knee replacement can absolutely make a complete restoration of all of those complex movements. What matters? We want them to survive. We're judged on that. So they need to have a balanced transmission of load across the implants. We need stability, so there's less shear stressing in there. We have improved the materials a lot. The plastic, for example, has got massively better. And the dynamic and the in vivo stuff, we are still learning about, but we're learning and we're keen to. Now, in the short term, we do have problems with knee replacements. They are meant to alleviate pain and restore normal function, and they don't always do that. There's lots of studies showing around about 20% of people have dissatisfaction. There's lots of factors. This is just one of them. I think the patient selection and expectation management are probably even more important. But this is the title of the talk. So alignment. It's not just alignment, patellofemoral function, mental health, comorbidities, expectations, physio. All of these have to be right for your patient to come along and see you follow up and say, this is great, I've forgotten I've had a knee replacement. So the goals: restore the mechanical axis, balance the soft tissues properly, optimize the patellofemoral tracking, and then maximize the implant longevity. We do a lot of things. We do about 105,000 a year in England and Wales, but we're still not getting it right enough. So just in terms of the principles, we need to understand the axes of what happens. So the anatomic axes of the bones are a line drawn through the hollow middle bit of a long bone, which you can see on the left side there. The mechanical axis is slightly different. So that's where the forces run from the top of the bone to the bottom of the bone. So in the femur in particular, you can see the femoral head is offset quite a lot medially. So the mechanical axis runs medially downwards. In the tibia, it's closer to neutral in most, but not all patients. The way we measure alignment, we actually do it in surgery. There's a traditional technique. We put rods, which you can see on the right-hand side there, inside the bone, and then we put jigs off the end of that, and we can either fix the angles on the rods or we can move them to help with any particular issues the patient's got. We then pin a guide onto the bone, and that guide has got a little area in which a saw will pass through, and we use that to saw through. Or, more frequently these days, we can use technological things. Robots, as Sam demonstrated, navigation, custom guides, all sorts of bits and pieces, but there are things out there to help if you're interested in getting help. Right, the crux of the talk, the basic choices. So we can align them mechanically. What that means is we get the implants lying perpendicular to the force lines, so the force comes straight through and it's distributed perfectly evenly across the implants in theory. The idea of that is you then restore a straight leg, and we're not looking for varus or valgus deformities in the coronal plane. Everyone gets the same. The next option is restored. So we look at a patient and we say, you've got this type of leg, your varus, your valgus, you've got deformities, and then we try and restore it to where their native joint was when it was healthy. That needs a bit more effort. You need advanced imaging, you need measurement, and you may be putting patients back into a varus or valgus position. And then the final option is functional, where we try and achieve a stable and balanced knee based on individual mechanics and soft tissue tensions. So this one's a little bit different because we're then putting the emphasis more onto some intraoperative assessments, not whether it's a straight leg or not whether the patient started with a straight leg or not. So mechanical principles, pretty simple, and it's what the vast majority of knee replacements were up until 15 or so years ago. You cut the tibia perpendicular to its mechanical axis, cut the distal femur perpendicular to its mechanical axis, which is around about 6 degrees off its anatomic axis. We then need to turn it a few degrees externally, just to help the patellofemoral joint, so they build in around 3 degrees of external rotation. And then you end up with a straight x-ray like you've got here. It's a normal, simple implant, and there's a red line running through the middle of the implant, which you can extend up to the femoral head and down to the centre of the talus. It's familiar, we've got known implants, designs that match with it. It doesn't need expensive kit. It's quick for surgeons who like to measure themselves with a clock rather than any other measures, and you do get equal load distribution. But it is quite simplified mechanics. It does cause some challenges in balancing through flexion and extension, and there's a bit of a tendency that it tends to underset the lateral femoral condyle in varus knees, and if you do that, you're then trying to push the patella a bit more laterally, and you end up with overload and symptoms pretty similar to the ones that Rick was describing earlier in terms of patellar overload syndromes. So people then started looking at restoring it anatomically, aiming for an oblique joint line, and then made essentially implants that had an oblique joint line instead. Again, fairly simple, better weight distribution, improved patellar mechanics, felt more natural when it went well, but unfortunately it was kind of one implant. It failed a lot with polywear, and nobody really figured out whether it was the implant or the design. But it did then form the basis of a new technique of kinematic alignment, where patients have their restored natural joint line for them through a true resurfacing. So the femoral component aligns to the patient's native femoral condyles, tibial component to the native tibial plateau. You then don't need to do any soft tissue releases in theory, and then you end up with better gap balancing. But with x-rays, they can look a bit wonky. So you can use calipers, which is a way of measuring prearthritic sort of places, and then essentially you take off the amount of implant, the amount of bone and cartilage that would be replicated by the implant. It's very dependent on accurate cuts, whether that's calipers, navigations, PSI, or even robotics. It can give you some pretty odd-shaped knees. It certainly does seem to have, in its proponent's hands, a lot of patients feeling that there's a more natural feel and function. But there are some concerns that you might be putting these in a little bit too wonky. So the next concept people came up with was restricted alignment, whereas if someone had really, really varus knees, the old couldn't stop a pig in a ditch sort of shape, then they would do a kinematic but restricted, and they'd do an osteotomy to capture the last few degrees. That is starting to be fairly big operations. And then the next option is functional alignment, where you assess the individual patient mechanics, you then assess their soft tissue tensions, and then deviate the axis you're going to put the implants in to give you a stable and balanced implant. So it takes some aspects of mechanical and some aspects of restored alignment techniques but it will accept some deviations from a neutral axis. So the advantage is it will measure soft tissue tension intraoperatively, and it's dynamic. It combines well with other high-tech options. The disadvantage is it's expensive, high-tech implants and robots, etc., that need to be invested in. So it's not available to a lot of places. Thankfully, it is to everybody who practices here. So you can do it with imaging. You do a CT scan. It's the most expensive, but you do really have proper 3D imaging, and you can reproduce exactly what you want with robot assistance. It's the most work, the most cost, but the most accurate. And these are pictures, I won't go through them in detail, they're very similar to Sam's, just there's more compartments involved. You can do it without imaging, it takes away some of the expense, but it then really heavily relies on the surgeon measuring everything absolutely accurate at the time. I would say more and more cases are not so simple. These are selections of cases that present to our clinics. Kinematic alignment's not great with deformity, mechanical not great with high demand patients. So you have to accept the fact that there will be some sort of a compromise. Functional may have high problems with investment, but is easy to reproduce. Mechanical, cheap and simple. And also many will end up looking the same. So this is, as it happens, a robot functional alignment, but it would probably look very, very similar with any of the other techniques as well. Thank you.
Brilliant, and almost on time, so fantastic. So I've got a quick case that we can go through, and then we'll take questions. We'll probably get the guys up here as well if you've got questions for them. But if we go through the quick case first, this is a patient of mine. I'm really interested to hear what the guys up here think and where we might go with this one. Clicker's not advancing. I need to be doing something else. There we go. Thank you for switching it on. So this is a patient who came to see me. She's a 64-year-old. She's a marathon runner. She had set herself a challenge to run a marathon a week for a year, which she did. She found it really difficult to finish the last one. I know what you're thinking, that 50-second marathon's always a bugger, isn't it? And she had to walk to the end, but she still did it. She finished it. She's extraordinary, this woman, honestly. She came to see me. She had a bit of a sore knee. So she came in, she had a limp, importantly she had neutral knee alignment. She had a little bit of an effusion in the knee, and she was tender over her lateral femoral condyle, right? So the lateral joint line was a little bit irritable, but actually she was more sore, so I could localise it more over the sort of lateral epicondylar region. No joint laxity. So investigations, what do we think on the panel? Vijay, what would you suggest would be the most, I guess, fruitful investigation when looking at something like this?
I mean, I can tell you, at Garden, we definitely go straight to MRI because of the history. We probably have a outpatient X-ray as well, but I don't think this patient walks out without getting anywhere near a MRI.
Okay. Everybody agree? MRI? Okay. Well, yes, but she's 64, so actually I'm also quite interested in the global health of her knee. So I would usually start with X-rays, to be honest, even though we will get to an MRI in a minute. I agree with you, an MRI is going to be much more useful in this setting. But I suppose in somebody I've just met, I want to know how worn is their joint to begin with, and that global assessment that you get with an X-ray tells you an awful lot. What do you think?
Oh yeah, absolutely. I think you know they're the two simultaneous things that are going to happen. One's going to happen once she's at clinic, and one's going to happen very soon after. I hope.
Yeah, absolutely. So we'll go straight on to the MR. Do you want to just tell us a little bit about what you can see there? I don't know how well you can see it down there.
So I mentioned the fat-suppressed MR sequence being your friend. This is a fat-suppressed MR sequence. I said that look for the areas that are white. You can see that the lateral femoral condyles globally and diffusely increased in signal, and she's got this sort of subchondral ridge of low signal. That's probably best seen on the image that's furthest to your right, and sorry, your left.
Right.
You're right. Okay, yeah. Sorry, I keep looking at that screen. I think that it's reversed. And you know, this is probably an insufficiency fracture. I think why doesn't she have more insufficiency fractures after 52 marathons? If I'm honest.
Okay, brilliant. So Rick, if you're seeing somebody like this with an insufficiency, bone injury around the knee, any other investigations you're thinking of?
Yeah, so you have to think of,
Yeah, you will be.
so you have to think of things like bone health. So you might be looking at general bone profile, check the calcium, thyroid, parathyroid hormone. You might be 64-year-old, be looking at DEXA, past history of osteoporosis, family history of osteoporosis, stuff like that.
Okay.
Diet.
Okay. So DEXA there showing a little bit of reduction in bone density, but actually not too bad globally. So I think we've got a diagnosis, which is insufficiency fracture, so subchondral fracture of the lateral femoral condyle. We've probably got understand something of the mechanism, 52 marathons in a year, maybe some of the underlying biochemical or metabolic issues that might be leading to it. Jim, what are you thinking in terms of treatment for this?
Yeah, so she's obviously overloaded her lateral compartment. 52 marathons, I mean, I would argue it's a stress fracture, not necessarily insufficiency fracture, but we need to somehow get that lateral compartment to heal again. And
Could you differentiate between those two? You just made an interesting
Yeah.
statement about a dichotomy between insufficiency and stress.
I would.
So what do you mean by that?
Right, so stress fracture has got reasonably normal bone with abnormal stresses, which obviously she's been placing on it. Whereas I would class an insufficiency as abnormal bone with reasonably normal stresses.
Okay.
Usually it's a combination of the two, don't it?
So it's a load versus load resistance relationship, and either the load's too high or the resistance isn't high enough. Yeah. Okay, fine.
But that lateral compartment needs to heal. Now, it may be just stopping running, maybe giving her crutches or realigning with her brace might do the job. So I would not be rushing in the surgery here.
Okay.
She's just done something really.
Okay.
Yeah.
A surgeon does want to operate. Excellent. What happens to the rest of her while she offloads? So she's 60. Well, I say 64. I think at the beginning. So one of the things I'm thinking of, and you're quite right. So stress injuries around the joint, we often go straight to crutches, offload. And one of the issues is, of course, as you get postmenopausal, growing back muscle and losing lots of bone mineral density is something so hard to reverse, isn't it? And so offloading completely, or even touch weight, whatever it is you're going to say, is then that needs to be managed in a slightly different way as well, right?
Yeah, I wouldn't touch weight with her. I'd actually put her in a corrective brace.
Okay. So a varising offloading knee brace. Okay. Yeah, good option. Okay. John, anything you would do differently?
Interesting, I've actually completed 52 marathons in 52 weeks, but
It was a long time ago.
they're now called snippets. So, and they do ultra ones, which are really good as well. I think you want to have a look at her long leg alignment and see where she is. You need to sit down with her for a while and try and understand where she is in her running sort of career. There are some people that this will be the halo event that they really want to do, and then will accept the fact that they can try and do something else. I would try and give conservative options. She needs to have calcium support, vitamin D support. You'd actually consider reducing osteoclast activity if there's any evidence of osteopenia as well. Offloading her with a varising brace, introducing her to a swimming pool would all be a very good plan, and I would try that. And the big carrot to dangle here is that you can stay away from my operating theatre, and that's a very good thing to do.
Very good points, one and all. And not to spoil anything, we did all of that and some. Yeah.
So those are the two questions I'll ask is, when in the 52 marathons do you think her first symptoms first started, that she started running through it? And two, isn't 10 marathons a pretty good to like establish her that you've got a pretty good baseline of bone health already?
Yeah, so this is a proper overload, isn't it? I mean, so she had symptoms probably right from the get-go, but she's a marathon runner. She runs through pain. That's what she does, right? And that's her identity as a person. And I'll show you in a minute. But yes, so John, just to say, we did all of those things. The hydrotherapy, I think, is really important for these as well. So they keep loading the muscles, but not necessarily the bone in quite the same way. But we did something else because she was in quite a lot of pain, and we did a bisphosphonate infusion, which helped with the pain. So there's some evidence it helps resolve bone edema, which is associated with the pain a little bit faster. And she had 2 infusions, and it made a really big difference to her. You might say it might not be such a good thing. She goes back to running, but the MRI scan 6 months later shows that this is on what? Vijay, what do you think? Sorry, jumping in.
I think I'd be saying that there's been almost complete resolution.
Yeah. So whether it would have done that without this one, I can't tell you. We haven't got a series of 300 of these. This possibly makes a difference, but it seemed to make a difference. Certainly to her symptoms in this case, so much so we did write her up. And the reason she came to mind when I was asked to me 6 months ago. This is now 10 years on from the initial presentation, with lateral knee pain. Guess what? She's got recurrent swelling. She's moved from marathon running into ultra marathon running. I kid you not. Yeah. And she says, listen, this is all well and good, but I've got to do my 10th Comrades ultra marathon in 4 months. Get me there. I said, what? So, guys, Vijay, what can you see now on the X-ray? That's the only view I've got. I'm so sorry. There is a Rosenberg that shows a lot more loss of
No,
joint
I think
space.
she's lost volume in the lateral femoral condyle. There's geographic signal mounted sclerosis. It looks like it's starting to collapse. I'm guessing that you're going to sort of like emphasize the contents of your talk earlier.
Well, maybe. Rick, anything you can do differently at this point?
You might think about, if she's not keen on going straight to operation, you might think of injections, and there's various types of injections you can look at: steroid, hyaluronic acid. Probably a bit far gone for PRP type injections, but you can talk about that.
Okay.
If the aim is for her to do that,
Yeah.
ultramarathon.
So I've got 4 months to get her to the start line. Jim?
Yeah, I mean, if she wants to run again, there's no chance of trying to do an operation at this stage. But I think it might be worth getting an MRI anyway, just to see what else is going on.
Okay. Jim is pessimistic about surgery. Fair enough. John?
Yeah, I think I'd be interested to have a look at an MRI and just see if there's anything else on there that you could do. If not, then if she's very inflamed, you can use one of the inflammation damping type injections. I'd probably try and
I
stay
can speed
away from
along
steroid.
because this is what we did.
Yeah.
We did an arthrosamid injection. I'm a bit hit and miss with arthrosamid. I'm sorry to say that in a forum like this, but I'd say about half the my patients who've had this have done well, and half the patients haven't had much of an effect of it. But it is a new injectable, basically like a plastic lining in the joint that you inject. It stopped her knee pain so much that she was able to train. She ran the ultramarathon last weekend, and she had to stop at the 77 kilometre mark, which was 15k short of the finish. So she was in my clinic yesterday, and we're doing a partial knee in a couple of weeks.
She's going to run again.
Yeah, she's doing it next year. This is her 10th. If you do 10, you get a big medal and a big T-shirt.
She's going to run a partial knee.
She's going to run on the partial knee, absolutely. And I'll show you in another 10 years what that's done. Thank you very much. Should we get the hip guys up though? Quick Q&A. Audience questions.